Back the patient to Valerio. Valerio did the orthodontic treatment, and he planned it together with Mirko Raffaini. He's a very good maxillofacial surgeon that we had. And Mirko Raffaini did the orthodontic surgery. And that's it. So these are very old, it's a very old case. So as you can see, these are original slides, you can see them. So you cannot crop, make bigger, shorter. This is how you should take the photos. And you see there are pockets, and we were in 2000. Look, before the publication of the minimal invasive approach, okay, as minimum as you open, as minimum as you can, with the aim to keep the clot stable, we were doing already. I mean, I was doing, this was 2000, the beginning of 2000. Because I had to present these cases in June 2000 to the Iperio that was in Geneva at that time, in the 2000. And I was one of the speakers presenting endogen. And I needed cases, so in all these intrabony defects, I used only endogen because I needed material to show. And as you can see, Laurel Gotlo, and then this is before and this is after. So there is no more pocket depth. And now this is before and after this time. See, it was like 6, but look, at the end is 1. And this was the old filling, and we changed the filling with a composite one. And this is this intrabony defect. Now I will do a little bit different. Still minimal invasive, but I will just cut in this way or this way. And then you raise the buccal papilla, clean, endogen bios, suture. At that time I was doing again microinvasive, but the papilla was cutted, you see, in this way, and reflected lingually. So I could clean, place endogen alone, and close and stable. Okay, and if you notice, this is the filling, and this is the filling. This is the filling, and this is the filling. So there is no more recession. There was the one that was before is also after. But the pocket depth was 7, and now it's 2 or 3. Okay, we changed the prognosis of these two. This side I will do differently, because this side, you see, it's 8 millimeters pocket depth, and this is an edentulous area, and this you can see three-dimensionally. There is an invagination of the tissue. But I want to treat the intrabony component. So what I do in this case a crestal incision, circular, and that's it. Look, no verticals, very easy. You can see, remove the tissue into the intrabony defect, and again, 2 normal sutures done. But because of this invagination, if you want to move the teeth orthodontically, you know, and this is the project of the PhD of Angelina. If you make some perforations in this cortical bone, you accelerate the orthodontic treatment. Or with a piezo, or with ultrasonic instruments, or with a regular drill, it's up to you. So if I do today this case, I would make a vertical here. I will raise a little bit bigger flap, and I will do some perforation here. And because we squeeze, and this is narrow, if you squeeze, it will be even more narrow. And so we create an area very bad anatomically. So, as you will see, and I would put today some bios with a bioguide membrane, 2 pins, 1 pin, just keep it stable. Because if you place just bios, a membrane, and you close, nothing happens. This is not regeneration. You have to fix, okay? You need to put the pins, and then you put the bios inside. You can make some perforation more, and then you close and you put another pin here. So you will augment this area. And I mean to augment the bone. Why? Because otherwise at the end it's good, because it's only 3 millimeter pocket depth. But look the anatomy here. This is not good. It's not in aesthetic area, but it's not what I want. And now to put your hands here.